Myself, Dr. Samrat Madnaik, and in coming time, I'll be talking about TE for CABG. So basically, what we are going to do is we are going to go through the basic views that we require in a patient who is posted for CABG, and I'm also going to try to show you some advanced imaging in the form of 3D and 4D. Just a word about it, not much. So disclosures, anything wise in the presentation you should credit to the many experts who have preceded me. Anything foolish, please assume it as my error in this presentation. So this would be the objectives of my talk. We'll go through history and introduction. We'll see about the basic TE views. We'll do the assessments like the baseline assessments, the intraoperative assessments, and the post-operative post-procedure assessments, and then there will be some key points. So to begin with, I always wonder how they used to anesthetize the people in olden time. Maybe like this. Well, I'm glad I'm not in that era, or this talk wouldn't be happening. A quick question to all of you. Can you guess who's the most famous personality of this century? Any random guesses? Trump. Okay. Great. Any other guess? Modi. Great. I'm sure both of them are. But for me, this is the most famous personality of this century. Bats, notorious for coronavirus, COVID in this era. But you should also remember, they are credited for the advent of ultrasound. They travel with the help of ultrasound waves and not vision. So this was known long back. A word about history. Lazzaro Spallanzani, way back in 1700s, he was an Italian physiologist and a priest, and he said that bats relied on sound and not vision for movement. So that was way back in 1700s. From that era, we have come to an era of advanced imaging, including 3D and 4D and strain imaging, and it has been an commendable progress. So I traveled yesterday night from Karat to Maharashtra. Suppose we are traveling from place A to place B. So this is our scheduled route. I traveled from Karat to Sambhajinagar today, and suppose we are traveling by car. Now I give you two options, car A and car B. The options are in front of you. What would be your choice? Quick answers. 50% of you car A, 50% of you car B, right? Now I add some more data to it. Now car A has a speed of 100 kilometers per hour. It has got 6 airbags and it has got an ABS. Now what is your choice? Car B is the same. No more data. Car A, right? Obviously. Let us see what car A is and what car B is. So this is your car A. This is your car A and the second one is your car B. So why did you make this choice of car A? That is because I gave you some more data. In the words of Lord Kelvin, he says that when you can measure what you are speaking about and express it in numbers, you know something about it. But when you cannot measure it, you cannot express it in numbers, your knowledge is meager and of unsatisfactory kind. So we have come a long way from this era, which included some invasive hemodynamic monitoring and some advanced monitors, to the current era of Transoesophageal Echocardiography and advanced echocardiography, which has added to the armamentarium and which is helping us in improving the patient outcomes, especially in the critically ill patients. Now, why TE in the perioperative period, especially for CABGs or overall in cardiac surgeries? So it has become the third eye for the anesthesiologist. It is a powerful diagnostic tool. It guides in cannulation, it provides vast array of information, it has real-time monitoring which is feasible during surgeries, and it does not interfere like transthoracic echocardiography, like lungs and obesity does not interfere it. Now why TE for CABGs? What is the role of TE in CABGs? So this is one article from JS in 2021 which says TE was associated with lower 30-day mortality and incidence of stroke after CABG. So this is a recent article from JS. Another article from JACC, again it says the same thing, decreased operative mortality and stronger benefit in high risk patient groups and 5 times more higher detection of additional valve diseases which change the surgical plan. So this again is a recent article from 2021. Coming to 2025, again one article from JAMA says yes, definitely TE intraoperatively in CABG patients, it helps in low or medium volume centers to improve the outcome, but at high volume centers the outcomes with the use of TE or without the use of TE, they remain same. But in spite of all this, then why TE use, especially in CABGs, is not a class 1 indication? So all of you should remember it is a class 2A indication in cases of CABGs and not a class 1 indication. So why is that so? Why are societies not yet able to put them or convert them to class 1 indication? And that is because RCT, that is randomized controlled trial evidence, is lacking, and that's why we still don't have it as class 1 evidence. But maybe in the coming time it might get included in class 1 indication. So we all know about the Chakravyuh. Abhimanyu knew how to enter it, but he did not know how to come out of it. Similarly, in the during the surgery, especially in the surgery, cardiac surgery, especially in CABGs, sometimes you can end up or land up into situations where you can't take the patient out of the critical situation. So for that, we should be thorough with our knowledge regarding TE in the perioperative period, especially in CABG patients. Now, like there are 5 elements in the nature: the sky, air, water, land and fire. Basically, there are 5 things that you should know for the role of TE in CABG, and that is to supplement the cardiac workup, which has already been done in the form of transthoracic echocardiography, to diagnose impact of previously unrecognized pathology or surgical procedure, to assist the surgeon in conduct of circulatory management, that is cardiopulmonary bypass, to facilitate the conduct of circulatory management or surgical procedure, and to diagnose cause of acute cardiovascular complications. Now, to begin with the basic views, we all know, I am not going to go into the details. The first view that you should know is midesophageal 4-chamber view. You can see here the multiplane angle is at 0 degrees, LA, LV, RA, RV, tricuspid wall and mitral wall. The second view here is midesophageal 2-chamber view, multiplane angle at 90 degrees, LA and LV. You can see the LA appendage over here. The midesophageal long axis view, we all know it, multiplane angle at 120 degrees. You can see the LA, LV, the aortic wall, the aorta over here. This is the 4D image of the same patient. You should also know about the aortic wall short axis view. Dr. Desurkar sir has already explained very nicely in his previous presentation. I am not going to go into the details. Again, you should always screen the patients with midesophageal ascending aortic short axis view. Here you can see this is the ascending aorta, this is the pulmonary artery, the right pulmonary artery, and the main pulmonary artery branching into the right pulmonary artery and a part of left pulmonary artery. Midesophageal ascending aortic long axis view to know or screen the aorta, ascending aorta, especially for atheromas or added pathologies. Similarly, you should also know about the RV inflow outflow view. You can see here the multiplane angle is at 60 degrees, and this is the image. This is mid-papillary short axis view, and this is transgastric view. This is the golden standard for diagnosing regional wall motional abnormalities, especially in patients with ischemic heart diseases. Similarly, you should also always screen the patients for descending aorta, thoracic aorta, and the screening of descending thoracic aorta in the form of short axis views. It looks like this. This is the 4D image of the same patient, and the long axis views is always essential to rule out atheromas because they can be catastrophic. Now, this is how I usually screen the descending aorta. This is a 4D screening. What I have done, I have begun from the lower part. That is the lower part of the descending aorta. I am going above. So you can see the aorta, descending aorta. We are screening this, and this is in real time 3D. This is in real time 4D. Here now, almost this is the beginning of the arch, and you can see the aorta is clean. So basically, the risk for stroke in this patient is going to be very minimal. Now, baseline assessment. What do you need to do? First and foremost, you need to know the ejection fraction, or you need to confirm the ejection fraction, and these are based on different methods. Most commonly followed method is the Simpson's method, the Simpson's disc method. And again, during the demonstrations we'll go into it. I'm not going to go into the details right now. It can also be done with the help of automation in this era, with the help of automated softwares which are available with different companies. Similarly, eyeballing is also very essential, especially for rapid assessment. Now, in this first image, if you see here, this is a transgastric mid-papillary view. This is a short axis view. If you see here, all the regions are contracting nicely. So basically, with eyeballing in this patient, you can say the EF is basically good. So it is almost normal EF. You cannot exactly tell how much EF it is, but you can give a range whether it is good, whether it is bad. In the second patient over here, you see this is the anterior wall over here. There is hypokinesia at the anterior wall. Okay. So basically, this is not a normal patient with normal EF. The EF is slightly reduced, somewhere around, I'll say around 35 to 40%, somewhere around that range. Similarly, in this era, we are also doing advanced echocardiographic parameters, and strain imaging has come in a big way. And the advantage of strain imaging is it is not subjective like eyeballing or looking at the regional wall motion abnormalities, and it is not operator dependent. So there are some advantages, but it also takes some time. In the same patient, I have done some advanced echocardiographic images. This is bullseye. And this is again a strain analysis, GLS in the same patient, and some myocardial work index and work efficiency in the same patient, which appears to be reduced. Now, after LV function, always remember, in any case of CABG, never ever forget to look for RV. So baseline assessment of the right ventricular systolic function in the form of fractional area change has to be done. I'm not going to go into the details because we have a lot of further things to go. If anyone wants, I can give the slides later on. Another assessment for right ventricular systolic function is TAPSE, that is annular plane systolic excursions. We all know any value above 17 is considered normal and anything less than 17 is considered as abnormal. This is how TAPSE measurement is obtained. So basically at the lateral annulus, you just place the M mode. This is a midesophageal 4-chamber view, and at the M mode you get this systolic excursions. Just measure those excursions and you will be getting a value. Here we have got a value of around 30, so which is good RV function. Now the next baseline assessment that you need to do in a patient with CABG is regional wall motion abnormalities, or looking for regional wall motion abnormalities. Now there is a 17 segment model of the left ventricle, and based on these 17 segments we can tell which area is actually going haywire, or which coronary artery is basically involved in this. So in the first image, what you see over here, this is a midesophageal 4-chamber view. Here the different supply by the different arteries is marked in different colors. So this area which is marked in orange, this segment number 2 or 11, this is supplied by the RCA or LAD. 16-17 number segment is supplied by the LAD. 14 number segment is supplied by the LAD or L6, it can be L6, and this 8 and 2 number segment is supplied by the L6. Similarly, in 2-chamber view, in long axis view, the mid papillary short axis view and the basal short axis view, all this together can be incorporated in 17 segments, based on which we can get a wall motion index, and based on this wall motion scoring index we can tell whether the LV function is good or bad, or where exactly what coronary artery is going haywire. So now there are different ways of grading RWMA. So one is normal, that means radial shortening which is occurring, it is more than 30%, or myocardial thickening is good, that is it is good, that is plus. In mild hypokinesis, the radial shortening is between 10 to 30% and the myocardial thickening is less. In severe hypokinesis, it is more than 10 or less than more than 0 or between 0 to 10, and thickening is very less. In akinesis, basically radial shortening does not occur and there is no myocardial thickening, and in dyskinesis there is systolic lengthening, and in regarding the myocardial thickening there is always systolic thinning seen in dyskinesis. So basically remember, this is good contractility, this is hypokinesia, this is akinesia, this is dyskinesia. Okay, and aneurysmal means whenever there is ballooning out or bulging out which is occurring, that is called as aneurysmal. So again the same thing. Now basically this is a diagram, we in GLS we call it as bullseye. Here it is a left ventricular segmentation, and we all know this. So there are 6 segments at the basal region. So this is basal anterior, this is basal anteroseptal, this is basal inferoseptal, this is basal inferior, this is basal inferolateral, and this is basal anterolateral. Similarly at the mid level, the apical level, and 17th segment is the apex. So these are the 17 segments, and based on this, how the motion of the segments is occurring, there is wall motion score index. So normally whenever the motion is normal, we give it a score of 1, hypokinesia score of 2, akinesia score of 3, dyskinesia score of 4, and aneurysmal we can give it a score of 5. So basically wall motion score index is sum of segment scores divided by number of segments analyzed. So if the score is about 1, we say it is normal, LV function is normal. If the score is between 1.1 to 1.5, we call it as mild dysfunction. Between 1.6 to 2, we called it as moderate dysfunction, and anything more than 2, we called it as severe dysfunction. Now in this image, if you see here, this is a midesophageal 4-chamber view. What do you feel? What are the positive findings in this image? Quick. So if we see here, this distal IVS and part of apex, this is hypokinetic. Okay. Same patient, again if you see here, this is the anterior wall, this is hypokinetic, also the LV is dilated. This is midesophageal long axis view, again if you see here, this is hypokinetic, rather you can also call it as akinetic. So basically what are we dealing here with? A primary impression, something with the LAD territory, right? Same picture, same patient in the transgastric short axis view. This is at the basal level. This is at the mid papillary level. Again, this is the anterior wall over here. You see the segments are hypokinetic. So basically this patient had an LAD territory infarct, and same was proved with the help of GLS. This is the GLS imaging of the same patient. The GLS score is -5.4. This is a bullseye of the same patient. You can see GLS score of -5.2, and all this region, that is the anteroseptal region, has got the erroneous GLS results. Okay, so basically this is proved with the help of GLS, and this patient had LAD territory ischemia. In this image, what do you see over here? So hardly anything is moving. Okay, so this was a patient who was just underwent a cardiac arrest, and this was image just taken during that time. But just for demonstration purpose, I wanted to show it to you that all these regions are akinetic. So this becomes somewhat like global hypokinesia. Okay. Now, one of my clinical experience with the use of the modality of GLS or this wall motion scoring. So I had a patient who was posted for vascular surgery. It was an RFA ablation. My surgeon required general anesthesia. So I intubated the patient. He was taken in cardiac OT. Sometime after induction, patients had unstable hemodynamics. I tried to give some fluids, some vasopressors, but it was not responding well. ECG was somewhat normal. There were no major changes. Fortunately, I had the TE probe with me. I just inserted the TE probe, and to my amazement, what I found was the GLS scores in the inferolateral lesions were quite less. So basically, I told my surgeon to wrap up the surgery. It was a short procedure, so we wrapped it up. And I had given him heparin, unfractionated heparin, because during the procedure we required it. Started him on small dose of Nicoran. Post-operatively, we did an angiography, and the culprit vessel was RC. So this was proved with the help of GLS, or this was situation was averted, or I could diagnose it because of Transoesophageal echocardiography. Now, the beauty of this thing is GLS can diagnose subendocardial ischemia way before actually visually you start looking at the start seeing changes based on TE images. So that is the beauty of GLS. Second thing, always remember TE captures ischemic changes much more faster as compared to electrocardiography or hemodynamics. So first changes what are going to occur, they are going to occur during echocardiography, that is with the help of TE or with the help of your advanced echocardiographic monitoring parameters like GLS. Now another patient I had, another clinical example. This patient we operated for CABG. Fortunately, intraoperatively everything was good. Post-operatively, post-op day 0, that is, and the same day in the evening, she had some weakness of her left arm and left leg, and she was a bit disoriented. So we did a CT, and to our amazement, there was evidence of stroke. So basically, if you look, baseline assessment of the aorta, especially the descending aorta and the ascending aorta, is very essential in patients who are posted for CABGs, because a lot of manipulation occurs during the procedural part. And always remember, the thickness, composition, irregularity of plaque, complexity and location will always result, or these are the factors which affect whether the patient is going to have stroke in the perioperative period or no. Now, there is grading of this aortic atheromas. This is called as CATS classification. So we in this CATS classification, the atheromas are graded into 5 types. One means normal. Second is extensive intimal thickening less than 3 millimeters. 3 means the atheroma is protruding less than 5 millimeter into the true aortic lumen. 4 means it protrudes more than 5 millimeter in the aortic lumen, and 5 means mobile atheroma. Based on this, the percentage of incidence of stroke of the patient changes. So if you have a mobile atheroma, there is high chance that patient can land up in perioperative stroke. So always remember, you have to screen the aorta for evidence for presence of any atheromas before going further. Now in this image, what do you see here? This is Prince Charles trying to take an aim, but he is blindfolded. So is it going to be easy? Well, no. But if he has the assistant of his, maybe an anesthetist or a well-trained person who does TE, then definitely the outcomes are going to be good. So a few clinical examples. So if you see here, this is descending thoracic aorta. If you see here, this is less than 3 millimeters. Okay, this is an plaque, atheromatous plaque, and this is less than 3 millimeters. Again, same thing over here. So the incidence of stroke in this patient is going to be very less. As compared to that, if you look at this image, this is a mobile atheromatous plaque. you see here. So definitely there is high incidence that this patient can land up into perioperative stroke. Again, another patient who was posted for CABG. This is an atheromatous plaque, and this is CATS category type 4 atheromas. It is not mobile, and this you can see just it is at the beginning of the aortic arch. This is another patient whom we had cannulated, and the aortic atheromas just at the aortic arch was sitting right over there. So all these things, the perioperative risk can be reduced in patients if you have a good knowledge of TE. Same thing, as I told you earlier, always screening of the descending aorta is essential, and this is how we usually screen it. This is a 4D maneuver that we have done for screening of the descending aorta. So I always say, before successful outcome, you should never celebrate. So this is like, if you start celebrating too early, it definitely you are going to have your own goal. Okay. So in patients of CABG especially, without having a proper thorough evaluation, TE evaluation, never try to celebrate that you have successfully accomplished the surgery. The baseline assessment should also include assessment of different valves, which includes mitral valve. As in this case, you see there is an eccentric MR. This is the 4D image of the same patient. This is a surgeon's en-face view, and you can see an A3, P2, P3 prolapse in this particular patient. Again, another patient, this is A2, B2 prolapse. Some part of A3 is also involved. Again, this patient has eccentric MR. So all this should be visualized before the surgery begins, well before the surgeon starts or begins his grafting. Similarly, you should never forget to assess the aortic wall also. So in this patient, the patient had mild aortic stenosis. 4D image of the same patient. Also, always remember, never forget AR, because AR again can be very tricky situation, especially if the patient requires IBP, and you should never forget to document this AR. Aortic regurgitation, again, I am not going to go into details. It is well classified or well graded with the help of vena contracta or with the help of PHT. And again, anything less than 200 is considered as severe AR. Between 200 to 500 is considered as moderate AR. Hollow diastolic flow reversal in the descending aorta, again, it is one of the very classical signs for documenting aortic regurgitation. You can see this is the descending aorta and this is hollow diastolic flow reversal which is occurring. So basically this is a patient with severe AR. Like AR, again, you should always have a look at the tricuspid valve. Never forget to look the tricuspid valve also. In this patient particularly, this is a patient with moderate TR and this was not documented early. Again, you can see this is again an en-face view of the tricuspid wall. You can see the regurgitant jet over here. Now look carefully in this image. What is happening over here? A politician is trying to talk to people in flood affected areas. A child is being subjected to violence. But is it the truth? Well, absolutely no. So similarly, before comprehensive TE examination, you should never come or give your confirmatory results. Now, one thing what I'd like to tell you here, especially for the beginners, that always remember, whenever you are doing Doppler interrogations, your line of interrogation has to be as parallel to the blood flow as possible. If you are going to do it in a perpendicular way, suppose this is the blood flow which is occurring, and if you put your Doppler profile in a perpendicular way, the signals that we obtain here are very bad. And as contrast to it, if the Doppler profile or interrogations are as parallel to the blood flow, then the signals are going to be good. So why do I need to tell you that? Is because in short, we'll see how we can calculate the cardiac output in few subset of patients who are high risk. So in this subset of patient, we have gone to mid-esophageal long axis view. You can see here the LVOT diameter is 2.18. So step 1 is calculating the LVOT cross-sectional area, and just put the numbers, that is pi r square, and you will get a cross-sectional area of 3.70 centimeter square. Next thing and most important thing is go to either deep transgastric long axis view, as Deepak sir has already told in the morning. You can always align your Doppler profile in a very parallel way to the blood flow in this particular image. Here you can put your pulse wave Doppler over here. This is at the LVOT. And once you put the pulse wave Doppler, you will be getting a trace somewhat like this. So you can just trace the LVOT VTI over here. It is 19.3. And once you put all the numbers together, that is, calculation of cardiac output is very easy. So stroke volume, basically it is nothing but the LVOT VTI into the area that we have calculated earlier. So this is 19.3 and earlier was 3.7. So this gives a stroke volume of 17.1, 71.4, and multiply it with the heart rate of this patient. So basically heart rate is 83 beats per minute. So cardiac output is 5.92 liters per minute, which is almost normal or normal. Similarly, with the help of TR velocities, you can calculate the right ventricular systolic pressures or the systolic pulmonary artery pressures. What you need to do is just at the peak of this, you just get the value that is there and make it, just add it to the right atrial pressures. And in this particular patient, the systolic pulmonary artery pressure is 74.82. Similarly, the mean pulmonary artery pressures, the diastolic pulmonary artery pressures can also be calculated. This can be calculated with the help of PR velocities. I'm not going to go into the details. Pulmonary capillary wedge pressures can also be calculated with the help of TE. Your right atrial pressures, without calculating the inferior vena cava, they can also be calculated with the help of this equation. Again, left atrial pressures can be measured with the help of TE. The LVEDP, which can be calculated based on the aortic regurgitation jet, that is the diastolic blood pressure minus 4 into velocity of the aortic regurgitation, the end point of the velocity of the aortic regurgitation jet. This can give insights into the LVEDP. Similarly, SVR can be calculated and also PVR can be calculated. So it is possible to calculate multiple things based on this TE, but always remember these calculations are very fine and any small results or errors in calculating them can completely compromise your calculation. So you have to be very fine and meticulous when you are doing this. Baseline assessment of the diastolic function is also essential in all these patients who are posted for CABG. Also, presence of any intracardiac shunts should be documented. In one of our patients, the patients had sinus venosus ASD, and this is the sinus venosus ASD from the LA perspective. TE and surgical impact, always remember TE impact on surgery is there. Overall 9% change in management occurs when you are using TE in patients who are posted for CABGs. The findings include, significant findings include 33% pre-CPB changes in the management and 8% post-CPB changes. And in high-risk patients, definitely the change in surgical plans occur when you are using TE. Conversion to on-pump CABG can also be, one of the factors in which TE can be helpful, and it occurs in 1.1 to 8.2% of patients, and TE always helps in decision to convert to CPB. Just a few words about the use of TE, especially in MICS and this robotic surgeries and endoscopic surgeries, which are coming up in a big way these days. So basically for SVC cannulations, TE can be used. This is a bicable view. In the first image you can see here, we are trying to insert the SVC cannula, which is going way too further. So I have just withdrawn it slightly back and then positioned it so that it can be exactly at the SVC RA junction. In the second image over here, tip of CVP catheter is being visualized because we are not very sure whether the CVP is in the SVC or no. Again, IVC cannulations can be guided with the help of TE. Again, midesophageal bicable view is one of the view which you should master for this. Hepatic vein assessments can also be done, whether the cannula, as Deepak sir told in one of his clinical example, whether it is the guide wire is going exactly towards your IVC RA junction or whether it is getting diverted towards this hepatic vein. This is again very essential. In one of our patients, it was difficult to insert an IVC cannula and the culprit was this. So anyone can tell me what exactly is this? This is an eustachian valve, a huge eustachian valve. 4D image of the same patient. So with the help of TE, we could guide this IVC cannula properly in the proper place. So that is how TE rescued us in this situation. Similarly, aortic cannulations, especially in MICS surgeries, whether the guide wire is in true lumen or no, this all can be documented with the help of TE. This guide wire, what you are seeing here is the guide wire which is seen in the true lumen. Same patient but different perspective. Aortic cannulations can also be guided with the help of TE. Again, I am not going to go into details of this 3D and 4D. Pump flows which are captured. Now, if you look at this image, what you are seeing here, students are studying, but they are studying on the wall. So, how could that be possible? So, if you just change your perspective, you will understand what the truth actually is. So, similarly, while doing TE, always remember you should make use of multiple views before commenting any final diagnosis. So, if in Western setups mostly they do CABGs, especially with the help on CPB and especially it is with the help of cardioplegia. So, guiding this cardioplegia cannulas is also one of the, it can be done with the help of TE, and especially this coronary sinus can be beautifully visualized with the help of TE if the surgeon wants to insert a retrograde cardioplegia cannula which goes into the coronary sinus. So what you are seeing here, this is the 4D image, this is the SVC at the top, IVC at the bottom, and over here what you are seeing, this is the coronary sinus. This is the coronary sinus in long axis. Again, IABP placements can be nicely done with the help of TE. Always remember, the tip of IABP should be distal to the opening of the left subclavian artery, and this can be guided with the help of TE. In one of the robotic surgery that we did, again here TE has helped me a lot, especially for guidance of the cannulas intraoperatively and to also prevent some catastrophic events. Now a few clinical examples. In the first image over here, if you see, the cardiac output is 2.1, the stroke volume variation is 18, the SVR is quite normal. I show you these images. What do you think based on the first image? So this is a transgastric mid-papillary short axis view. Both the papillary muscles are coming near each other. So basically this patient is volume depleted. You can safely give volume to this patient. Okay. In the second image, you see the IVC. This is not of the same patient. This is for the other patient. Just for demonstration, I have shown here. But the IVC looks quite dilated. So you have to be very watchful while giving volume to this patient. So this is how basically the RA pressure can be estimated based on the IVC measurements. Like IVC measurements, SVC variations can also give insights on the preloading conditions of the heart, and also peak VTI variations. This is a wonderful modality based on which we can tell whether the patient is fluid depleted or no. So peak VTI variations more than 12%, you can safely give volume to the patient. Another example, again cardiac output is less, heart rate is more, 138, BP is 71/60, CVP is high. I show you this image. So what is going wrong over here? So basically, again, this is the anterior wall. The LAD territory is, almost akinetic. So basically, this patient had the issues with his LAD graft, and again GLS, we made use of GLS to show the same. And after an additional graft, this we could, breeze out this patient. Now similarly, SVR and PVR calculations can also be done. So afterload calculations can be done with the help of TE, but again, as I told earlier, they are prone for errors. So it should be done in expert hands. Deering maneuvers, especially in combined procedures like CABG with MVR or AVR, again, this all proper deering can be ensured with the help of TE. Device assessments, preoperatively if the patient has device, so assessment of those devices. This is a ASD device, and this you are seeing from the RA perspective. And this is from the LA perspective. This patient was posted for MVR with CABG. It was a case of mitral stenosis, previously underwent ASD device closure with triple vessel disease. Again, diastolic function can be measured in the perioperative period and the postoperative period. TE can also tell you whether the patient has pleural collections. So basically, it is very easy to visualize the left pleural cavity. One of the patient has, in this particular image, he has huge left pleural collection. So you can all diagnose this with the help of TE. So always remember that you should make use of different views in TE and not depend on just one view. Otherwise, you will fall in trouble. Few of clinical examples. This is an LAD artery huge aneurysm which was not documented earlier on transthoracic. Once I inserted the TE probe, you can see the huge LAD artery aneurysm almost compressing the LV. So they had mentioned it as low ejection fraction and some small aneurysm. You can see this. This is a 4D image of the same patient. This is the aortic wall you are seeing here, and I'll just rotate the image right now. So this is the left ventricle, and this is the huge aneurysm, LAD aneurysm, which is there, this one. So all this can be nicely documented with the help of TE. Another example, this is a circumflex aneurysm. Patient had undergone circumflex artery stenting, PTCA, and again in a few months turned up with aneurysm. So again, this was beautifully documented with the help of TE. Over here you can see this is a 4D imaging of the same patient, and this part is the aneurysmal part. In a few unfortunate situations, sometimes you can land up in aortic dissections, especially with newer surgeons or people who are untrained. And in one such patient, we had an aortic dissection. Basically, this was a case we were doing on CPB, and Since the surgeon was junior, during aortic cannulation there was a flap which was iatrogenic flap which was created, which was diagnosed with the help of TE. Again, same patient, this is the flap that you are seeing, which was successfully picked up and successfully treated at the right time. Patient outcome was good. Now look at this image. This is flooding which is occurring. The reason is more rainfall. Again here, this is flooding, this is occurring, but the reason is increased in pressure. So the outcomes are same, but the causes are different. Similarly, suppose you get a situation wherein you have put advanced monitors in place. The heart rate is 110, the BP, systolic BP, the arterial blood pressure is 120 by 72. The pulmonary artery pressures are 135 by 45. What could be the reasons? Okay, one is zeroing. No, very good. Yeah, correct. That is there. But apart from that, there could be multiple reasons, but TE comes to rescue in this place. It can be either an pulmonary embolism which has occurred. There are documentations wherein people have or patients have had pulmonary embolisms intraoperatively during CABGs, or it can be also due to low ejection fractions, especially with very poor EFs, and this can be diagnosed or differentiated based on echocardiography and basically TE. Can renal assessment be done with the help of TE? Can kidneys be visualized with the help of TE? So yes, it is possible to visualize especially the left kidney, and in one such patient I have tried to visualize the left kidney because he was a patient of CKD. We were doing an CABG surgery and we had to do it on pump because it was a patient of low EF. So this is the left kidney, the left renal system, which we have captured in 4D. Again, you can see before going on bypass, you can see the systolic, this thing, pulsatile nature of the flow, blood flow. Once on bypass, you can see almost this is near normal or baseline. This is on bypass, and this you can see these are the pump, flows which are being captured. So this is also possible. So always remember, eyes see what the mind knows. If what are you able to see over here? Well, maybe a skull or maybe a lady who is trying to sit in front of the mirror. So similarly, you should have the knowledge about TE and you should be able to, think in multiple ways and try to come to a definitive diagnosis. Now, just last 1 or 2 slides. What is going wrong over here? So basically, I'll give you some clinical hints. This was a patient who was posted for CABG. Towards the end of the surgery, patient had ventricular fibrillation. And in spite of multiple attempts, the VF did not, budge. It was not responding. So surgeon decided to give cardioplasia for a while, put it on pump. And what was happening was the LV was getting distended. And surgeon was not able to identify that. But since there was a TE probe in place, I could tell him, and he did put a LV vent afterwards. After giving rest for some time, the patient came off bypass very well. So that was the beauty of TE. Another second example, this patient underwent CABG, chest was closed. Patient previously had anterolateral wall MI. The anterolateral wall was scarred. Intraoperatively, absolutely went well. The only thing that was positive in this patient was the lateral wall, it appeared to be scarred. We closed the chest, the TE probe was in place, the hemodynamics dropped down, and to our amazement, this was what we found. So basically, the octopus, what we had put, it had caused rupture or the part on the lateral wall of LV, and which led to an LV tamponade. So we could diagnose this. Unfortunately, we tried a lot for this patient, but could not. The patient succumbed. So my take home message is a thorough understanding of the anatomy and physiology of the heart is important. T plays a vital role in the perioperative period. Use multiple views before coming to a final diagnosis, and you should get acquainted like spectral tracking, 3D and strain imaging. These are a few of my references. Thank you. Do a quick demonstration of how actually we can diagnose the regional wall motion abnormalities. So this is transgastric. So this is transgastric mid papillary view. Are you able to see? Yeah. So basically what is happening here, the lower part will be the anterior wall, the upper is the inferior wall, this is that part is the lateral wall, and this is the septal wall. So the lower part is supplied by the LAD territory, the upper will be supplied by the RC, lateral will be by the circumflex, and this medial part with the LAD and part of RCA on the upper side. Okay. So what is happening here, that anterior wall, if you see, it is hypocontractile. Okay. So basically there are issues with LAD territory. Okay, or LAD territory ischemia is there. Yeah, again M mode we have applied across the same this thing, and if you see, the excursions on the inferior wall are there, but on the anterior wall almost absent. Okay.